Thanks for joining today Meet the Expert session, which has the pleasure to invite to speak Professor Kent Doi from the Department of Acute Medicine at the University of Tokyo in Japan. Professor Doi is, among other honors, counselor on board, certified nephrologist of the Japanese Society of Nephrology and senior member of the Japanese Society of Nephrology, and he has published many publications in the area of acute kidney injury and disease. And Christian Halbert, who is an internist and a nephrologist from Diaverum Renal Services in Germany, and it has an affiliation as medical faculty at the University Hospital and Clinic for Cardiology and Angiology, including internal medicine and intensive care in Magdeburg, Germany. So welcome to our special guest today. We are indebted to BIOPORTO for having supported this Meet the Expert session, dealing specifically with NGAL as a biomarker for AKI in COVID-19 related AKI. And I will start immediately asking Chris, which are the patients do you think we should consider for NGAL measurement in the clinical routine?
Well, Claudio, thank you for having me here. I think related to your question are the patients which are at risk of AKI. We have ability to isolate these with risk assessment tools like the TARCA score, for example, and these would be patients with diabetes, arterial hypertension, potentially undergoing cardiac surgery, elective or non-elective, but also patients admitted to the emergency department or general ICU, for example, with suspected sepsis.
I think you're right in the sense that because of the importance of the likelihood ratio for a biomarker, we need to identify a patient with high uncertainty to develop possibly AKI. And Ken, in your opinion and your experience, what is the diagnostic advantage that NGAL can actually offer as a biomarker?
Oh, thank you for having me. So my clinical experiments told me that the measurement of biomarker will be helpful when we try to distinguish prerenal AKI from renal AKI, so-called. So if we're not sure at the beginning of the ICU treatment, so whether this patient will respond to the only fluid treatment or not. If the urine NGAL is pretty much high, then we will soon give up to fluid administration and switch to considering dialysis, etc. So that's a good way for clinicians to use urine NGAL.
So that's interesting. And in the past, we have discussed, I remember, about defining not only presence or absence of AKI, but also defining a little bit of the severity of AKI. So I'm asking both of our guests, starting with Chris, do you have specific cutoff values that you suggest to use?
Yes, actually, sorry. We compiled a number of cutoff values in a very large meta-analysis that we just published in AJKD. And for urine NGAL and acute kidney injury, these cutoff values would be for the overall AKI endpoint would be around the 80 nanograms per liter, whereas for severe AKI, which we by the time of the meta-analysis defined as the rifle states injury and failure, we compiled a cutoff value of 105 nanograms per milliliter. And for the first time in this meta-analysis, and other biomarkers had this information available before, but for the first time we also assessed cutoff values with very high sensitivity and specificity in order to be able to rule out or to rule in patients having the risk of an AKI event. Which is
so Kent, do you agree with these values? And what do you think is the negative predicted value and positive predicted value?
Okay, so yeah, basically I agree with Chris around the value of 80 to 100, 120. So, and I prefer to measure urine NGAL or other biomarkers serially. I mean, measure it today and measure it tomorrow. And I prefer to see the trend of the elevation or decline of urine biomarker. So measuring at least 2 different time points will provide very useful information. So that's my guess.
So this is a very important point, the concept of sequential measurements rather than one single measurement value cut off. I think that this will increase dramatically the level of specificity beyond any type of sensitivity. And actually, this comes to the point that is very, very important for me especially, which is the concept of subclinical AKI. Do you think that actually NGAL can provide information when creatinine has not risen enough to detect any condition of AKI, and even if it does not provide any KDIGO stage throughout the stay of the patient in the ICU or in the hospital, will this value of positive NGAL be important in subsequent situations? Chris?
Yes, I think so, yeah. We had in this meta-analysis a very high number of patients that actually were negative for the serum creatinine defined AKI, being it defined by rifle, KDIGO, or the Arkin criteria. But having the NGAL values over the cutoff values of their specific studies. So the subclinical patients are very relevant because they do have a limited outcome compared to patients which are NGAL negative. And we see these in a number of scenarios, in cardiac surgery, in the emergency department. And there are novel studies from Basu and colleagues that show these scenarios in children as well.
So Kent, you are probably aware that we recently published a paper on JAMA Open about possible new classification of AKI, including a stage 1S, which is basically a subclinical condition in which biomarkers are positive, but creatinine is not yet sufficiently changed to declare a stage 1 according to previous classification. Do you think that this is an important step forward?
Oh yes, I totally agree with your new idea. So subclinical AKI is what to say, would be applied so well, especially to the multiple organ failure patient or septic patient. So let's say for contrast-induced AKI, maybe subclinical AKI will not have so huge impact on the clinical, just a tiny elevation of serum creatinine plus tubular injury. But for thinking about sepsis-induced multiple organ failure, so elevation of urine NGAL or AKI biomarker will have a huge impact on subsequent organ injury, including kidney. So that's why I think subclinical AKI is a very important concept to manage this kind of patient.
Yeah, as you know, we have published a paper a few months ago where we demonstrated that patients who display increase in biomarkers, although they never reached stage 1, they are going to have a renal functional reserve decline after 3 months. And this shows that the damage may be present in the kidney, although it does not reach significant level to rise serum creatinine. So moving to the point of AKI in COVID-19, do you think, Kent, that the same mechanism affecting AKI in COVID-19 patients are somehow reproducing the picture that we see in septic patients?
Oh yeah, that's a very tough question. Partly yes and partly no. So let me think about the lung injury in COVID-19. They finally developed the so-called ARDS, very severe form of the respiratory failure. But before that, they developed a different phenotype of lung injury, which is called type L, very light lung without no edema, but very severe hypoxia. This hypoxia will be called as happy hypoxia because patient doesn't look like being suffered from hypoxia for a moment. Finally, the patient developed very severely ill and hypoxia and then required mechanical ventilation. I'm not sure, but a similar situation may happening in the kidney also. So partly COVID-19 specific pathway will be observed in AKI, but right now I don't have clear answer.
So, Chris, do you think that NGAL can be a real aid to the diagnosis of AKI in COVID-19 patients, especially considering the organ crosstalk and the possibility to treat the patient quite early?
Well, Claudia, I think we do not have so many studies reporting on biomarkers in COVID-19 at the moment, but there were this one study, it's from Kent, where it was very obvious that NGAL was a predictor of AKI very early in the beginning of the sepsis state, right? So I think it might reflect actually the tubular injury that may be induced either by viral replication or a tubular septic injury in the first place.
So we're getting to the close of this session, but I would like you guys to give me one sentence for, let's say, defining the use of NGAL in clinical routine and in COVID. Ken, I start with you.
Okay, so just Chris mentioned my study. So we observed very earlier elevation of urine NGAL, and AKI diagnosis was followed, let's say 5 or 7 days after. So urine NGAL is very sensitive to detecting tubular injury. This is true. So if you are worried about this patient will develop multiple organ failure, especially in COVID-19, I recommend you to measure urine or whatever AKI biomarker, including urine NGAL.
So Chris, your concluding remark?
Yes, so I think that regarding the subclinical AKI aspect and NGAL, it's very interesting that you will always need the clinical information of the patient with regard to the biomarker and also the serum creatinine and the urine output assessment. But it's obvious that also a negative NGAL test result or a positive NGAL test result with or without the clinical AKI, which is defined by the serum creatinine classification, they will both have prognostic information for your patient.
And if I have to conclude, I must say that once again, I think that using NGAL as a biomarker, maybe together with other biomarkers, can provide important prognostic and diagnostic information irrespective to serum creatinine, because the reason that we using these biomarkers is the moment of uncertainty in which the test can be important to rule in or rule out the presence of a kidney damage. as a big supporter of the subclinical AKI concept, I think that, and also in light of the most recent ADKI publication in JAMA, I think that we may easily say that the use of biomarkers probably will be increasing in the next, let's say, months and years in the diagnosis and management of AKI. With this, I thank very much Professor Ken Doi. I thank very much Chris Albert, and especially BioPorto for organizing this Meet the Expert session. And thank you all for following this interesting discussion and conversation. Thank you.
Many thanks for
Thank
having
you.
us.